to see each of you coming in. I think this is our, third day, fourth day? I keep losing track of time. We have two announcements this morning before we get started with the plenary session. One is, unfortunately, some transport logistics have interfered this morning, so we will do the daily summary of yesterday's highlights tomorrow morning together with a summary for tomorrow. So 8:45 tomorrow we'll do those, and we start with the plenary presentation right now. I also would like to alert you to the early morning sessions tomorrow morning. There's one on medicines and insurance coverage, but then there is another one that does not appear by title in your program books, and that is a session that the Access to Medicines Foundation is hosting on the role of pharmaceutical companies in medicines access and use, and we'll invite you to participate in that session as well. And without no further ado, I hand it over to the moderators for this morning's plenary. Thank you so much.
Thank you very much, Anita. Good morning, everyone. Welcome to the new plenary session, which is going to take a little bit new format from the previous days. Let me introduce first of all just myself. My name is Clara Tisoki, and I will be moderating this session with Celestino Obua. And we are going to have a very exciting session. As I said, we are following a slightly different format because, first of all, we are going to have a debate with a very distinguished panel on how markets can work to reach consumers and how market interventions can work to improve rational use of medicines. And we are looking at two particular cases of malaria-related interventions through the Affordable Medicine Facility for Malaria and the Green Light Committee Global Drug Facility-related interventions on limiting access to second-line TB, anti-TB drugs to deal with multi-drug-resistant tuberculosis. So, and in the second half of the session, this is going to be our first part. The second half of the session will be dealing with gender inequities and how they impact on rational use of medicine. So first of all, I would like to introduce our panel, our distinguished panel of speakers and those who will be giving response in this debate. Dr. Anthony So from Duke University from the United States will be starting off the debate, posing some really interesting questions, how the system work, have they achieved actually the goals, but they were set out. And then we will have, Dr. Hoda Atta from Egypt, from the WHO Eastern Mediterranean Regional Office as the Regional Malaria Advisor, giving some responses to those questions. And Dr. Khalid Khalil, also from the EMRO region, as a GDF, as the Global Drug Facility Program Officer, touching on tuberculosis. And we have, from the ground, where lots of these interventions are taking place, from Tanzania with us, Rumad Vasi, a pharmaceutical management consultant, who can see that what is actually happening. So, without any further delay, I hand over to Dr. Anthony So to start the introduction for this. Thank you.
We'd like to thank ISHIM's conference organizers, particularly Anita Wagner, for bringing this panel together to highlight our public health community's continuing efforts to ensure the scale-up of access and rational drug use for patients in need. In this brief overview, I will try to frame some of the policy challenges that weave across the different efforts that scale up access and rational drug use, represented on the panel here, and to touch on the larger global efforts afoot that seek to actually shape the conditions under which our colleagues are working on the ground. In particular, we will emphasize the experience and lessons from initiatives to deliver treatments for TB and malaria. Even with this focus, though, there were certainly other perspectives that we just could not fit into the time allotted for a single panel. But we hope that at least the experience and evidence shared and the questions these presentations may spark will add to the wonderful discussions here ongoing here at ISHIM. We can describe access through various frameworks. The one I selected here follows the pharmaceutical value chain from bench to bedside. Like the hurdles in a race for a cure, there are challenges of therapeutic access, where treatments for public health priorities may or may not even enter the R&D pipeline, and the obstacles may be scientific or financial. Financial access is another obstacle and hurdle, where markets make available treatments but not necessarily at prices affordable to patients or health systems. And even when these medicines emerge out of the R&D pipeline and make their way into healthcare systems, they may not still reach patients. For good reason, much of our work has focused here in the delivery system on issues of structural access. Now, each of these hurdles to access correspond to a different part of the value chain: therapeutic access to the R&D pipeline, financial access to the marketplace, structural access to the delivery system. Scaling up access also has to be tightly coupled with rational use. A rising tide of access may lift all boats, but with greater use can come greater resistance, particularly to our first-line antimicrobial therapy. So approaches to targeting treatment for rational use must also be prioritized not only for averting unnecessary treatment and costs, but also to conserve the effectiveness of existing drugs. Just as shortcomings in structural access and rational use can force us to resort to more expensive second-line therapy, thereby raising the challenges of financial access and also to therapeutic access as well, so too, upstream interventions in the R&D pipeline and the marketplace can influence how we succeed or not in ensuring scale-up for access and rational drug use in the delivery system. So where in the value chain might we best intervene to make a positive difference? Public health is focused traditionally particularly on community management of the value chain, involving the triad of the provider, pharmacist, and consumer. How do we ensure that patients access not only the drugs, but also the diagnostic and health services that might make treatment more effective and timely? How do we ensure that the clinician follows the results of reliable diagnostics, even when those diagnostic findings are available? Well, two of our panelists, Khaled Khalil and Hoda Atta, will offer perspectives on where we stand and where we have yet to go with these approaches through the lens of TB and malaria treatments, respectively. At the level of the pharmacy or public clinic, however, access and rational use face challenges. How do we stem the use of monotherapy for malaria, where artemisinin combination treatments are indicated? And how do we ensure the availability and rational use of the more expensive second-line therapy when resistance has rendered first-line treatments ineffective, as has been seen for both TB and malaria? Historically, the Global Drug Facility and the Green Light Committee have sought to ensure the provision of quality-assured TB drugs. The Global Drug Facility has focused on DOTS, first-line TB therapy, and the Green Light Committee on DOTS Plus, or second-line therapy. Now, formerly, the Green Light Committee reviewed applications for second-line therapy and approved those which demonstrated good TB control, that is, good performance on DOTS. The availability of steeply discounted second-line TB therapy, as you can see here, had the potential to leverage and motivate the scale-up of treatment for MDR-TB, both access and rational use. But of course, there may be a paradox in that the greatest need for second-line treatment may be in places where rational use of the first-line treatment is weakest. And Khaled will share how the approaches taken by the Global Drug Facility and the Green Light Committee have evolved, responding to such concerns with plans to become more decentralized to the regions. Now, in malaria, a different approach is taking hold, the Affordable Medicines Facility for Malaria. Its stated goals are to sharply reduce the retail prices of artemisinin combination therapies, or ACTs, and widely increase access to these treatments, as well as to displace oral artemisinin monotherapies and other ineffective medicines for treating malaria, such as chloroquine and sulfadoxine pyrimethamine, to which widespread resistance has developed. The market-shaping intervention here has been to negotiate with ACT manufacturers to reduce the sales price of these drugs and to offer the same price to both the public and private sectors and the first-line buyers of those sectors, and to reduce the price of ACT to first-line buyers by providing co-payments to manufacturers. The hope is that over time, qualified ACTs will approach the prices of chloroquine and SP in retail outlets. Now, $216 million provided by Unitaid, the Global Fund, and DFID support the piloting of this intervention, a little upstream in the value chain. Complementing this, up to $127 million financed by the Global Fund would go to supporting interventions for safe and effective ACT scale-up. Now, one might ask, is this the right balance? Or if supporting interventions were repackaged to look more like a magic bullet, like a technology, a social vaccine, if you will, would these interventions have the starring role, not the supporting role, and command center stage? Now, There's been much use, of course, of piloting, there's been much discussion in our communities, particularly on piloting such a market-shaping intervention, and has not been without healthy and hearty scrutiny from many corners of our community. Some have raised questions whether scale-up of access and rational use ought not just to be for those in disease-endemic countries, but by local manufacturers in disease-endemic countries. And though we don't have the full picture here, we looked at AMFM's co-payments to manufacturers by the end of October this year from purchases made with first-line buyers. And we found that a third of the approved ACT manufacturers were multinational companies, notably Sanofi, Aventis, and Novartis, and also a third of the co-payments went to them. Now, if the picture on the ground is different, this may be from the part of the picture that we do not have the data, the voluntary pool procurement mechanism under AMFM and the President's Malaria Initiative. For our panelists to follow, we might ask, does this pattern matter? And if so, how does it matter? What if the unit prices for treatment are consistently lower from multinational companies than from developing country firms? Would that actually be persuasive for one pattern or another? We might also inquire where the AMFM investment is going, that is, which sector. As the pie chart on the right shows, almost 2/3 of the approved ACT orders have so far gone to the private for-profit sector, as opposed to the public or the private not-for-profit sectors. And again, for our panelists to follow, we might ask, where is the investment most needed and most effective? Well, how successful has AMFM been so far in ensuring ACT availability in target country facilities? From one of the Health Action International snapshot surveys in the 6 African countries targeted by AMFM, you can see generally excellent reach in the formal facilities. In unregistered or informal facilities, less so. Of course, the companion questions naturally are, did the co-payment subsidy lower the price of ACTs? And did the price fall to the point that they are competitive with and displacing the irrational antimalarial therapies, for example, artemisinin monotherapy, chloroquine, or SP? Well, the answer to the first question, as seen in these data, again from HI's excellent medicine prices survey methodology, shows that the median price of the AMFM ACT, in this case artesunate, lumefantrine, or Coartem in light blue. In dark blue, you have, of course, the non-AMFM originator brand, and in yellow, the non-AMFM lowest price generic. And in all 6 countries under study, the AMFM price bests the originator brand and the lowest price generic. To the second question, preliminary data emerging from the HI survey suggests that the AMFM ACT prices, while lower and approaching the prices of chloroquine and SP, they are not consistently lower. But of course, the picture is still evolving, and I would hasten to add that we're talking prices, not purchase patterns by households, which would require more in-depth evaluation. So finally, in moving from price to patterns of diagnosing and dispensing and consumer use, the panel will also hear from Romuald Mabasi, who will describe the ongoing experience with accredited drug dispensing outlets, or ADOs. Might ADOs be one of those supporting interventions working to complete the value chain for global market-shaping interventions like the AMFM? Some of their early work in Tanzania, as shown in this figure, suggests that the number of consumers seeking malaria treatment with ACTs gradually increased after the start of the pilot program, while the use of non-ACT antimalarials declined. Coming full circle, how do these approaches complement the more public sector-oriented community management approaches to scaling up access and rational use? To us all, we are watching these unfolding efforts, hopeful that we will find better ways of delivering treatment to those in need, and mindful that the limited resources available go to where they will leverage the most difference. And on that note, I invite the first of our panel perspectives from Khaled Khalil of WHO EMRO to share his thoughts on scale-up access and rational use on TB. Thank you very much.
Good morning, everybody. I'm going to present things about the challenges that we are facing right now in TB control regarding anti-TB medicine. Despite the the era of some initiative in the world like Stop TB Partnership and GDF and Global Fund as well. So TB control is not the responsibility of OMEOH. Several stakeholders are involved in TB control in the country, and the main bulk of cases, from 30 to 80% of the TB cases, seek their health care at the private sector for respiratory symptoms that could be TB. And this concern efforts are going to involve all the stakeholders in TB control through BBM, which is a public-private mix initiative. Nothing that there are problems in both, which is access that encounter coverage and financing and availability of TB medicine, and the rational use of drugs in terms of quality of medicine, following the proper treatment regimen and compliance to full duration for treatment. Now we're going to start for the challenge we are facing related to anti-TB medicine in the region. The first one is medicine regulation. Medicine regulation for TB medicine is in place. In fact, we're still facing some problems, some gaps in terms of anti-TB medicine widely available in the private market and dispensed as O2C. We have, unfortunately, some countries in the region still, they have huge quantities of TB medicine dispensed easily as OTC medicine in the private market, like Pakistan, Afghanistan, Somalia, etc. As we said, TB medicine are provided with or without prescription in some countries in the region without any control. However, some countries succeeded to have a framework actually to ban the sale of TB medicine in the private market, like some area in the Gulf, like Oman and Jordan and Syria and etc. The other point here as well is most of the local pharmaceutical companies in the region are out of WHO pre-qualified list. Some companies in the region don't follow actually the global standards in terms of the concentration, in terms of the quality, things like this. Likewise, pharmaceutical company in Pakistan, imagine that they produce something like 140,000 treatment courses yearly to the private market without control, in addition to a big question mark about their concentration, standards and their concentration and quality. Despite of that, some pharmaceutical companies in the region started actually to follow the WHO guideline in this concern. Like in Morocco, they just started working in the pre-qualification. The second challenge is actually here that medicine formulation. Fortunately, GDF provided to some countries in the region, more than 13 countries, with pediatric formulation. However, despite of that, some countries are still continuing reconstitution of adult formulation to the pediatric TB cases. And unfortunately, the local companies doesn't have the capacity to produce such medicine. The other point here as well, formulation of TB medicine are not fully in line with international standards like RH 150, 100, which completely out of the WHO standards in terms of concentration. Monotherapy as well is still dispensing easily in the private market. This promotes the risk of the monotherapy of rifampicin. Some companies, unfortunately, in some region, like in Egypt, still promote this initiative by production of such products.
Ahmed, you'll have to finish now.
Oh, sorry. So just quickly, the information system, we are missing such information system that can comply actually or give us clear idea about the consumption and the stock level. So this, unfortunately, this gap here lead to shortage of TB medicine. The last slide, sorry, I just want to take 1 minute. It's about GDF initiative and GLC. Despite of the era of such initiative in the region in terms of sustainable supply of TB medicine, continuing work in drug management and quality assurance as well, providing new diagnostics and technical assistance to drug management. However, still the region, they have a big gap actually to reach, or to comply with this initiative. I would like to finalize my presentation by one question, which is how can ASEAN 2011 can respond to the global problems of TB medicine? Last year, unfortunately, Mario, director of Stop TB Department, announced to everyone during the union that global shortage of streptomycin in everywhere. So we really need this time ASEAN 2011 can respond clearly to our problems in TB control. Thank you.
Thank you, Khaled. Thank you for sharing with us a multi-stakeholder approach really to TB, looking particularly at the GDF and the GLC's actually response to using regulation, formulation, and information systems to answer the challenges to the TB system, and the final challenge to the participants here at ISHIAM to address some of these issues. And our next presentation will be from Hoda Atta, who will discuss the community-based management approach for malaria in countries where AMFM has not been piloted yet. Hoda?
Good morning, everyone. I hope you upload my slides. I am going to take you to another arena because the first presentation focused about initiative to the private sector, AMFM, and I'm going to take you to our regional initiative in the region to support the delivery of malaria intervention at the community level. So I'm going to talk about scaling up community management of malaria, what we have achieved in the region, and some of the challenges. As you see here, we have these different level of delivery of malaria intervention, and I highlight in bold the home as the first level of delivery of acute illness like malaria, and then the community, followed by peripheral health services and hospitals. And this gives us the perception that we need integration and we need collaboration of all that level in order to reach the proper coverage of targeted intervention. The challenges we are facing is most of the cases, about 30 to 70% in the region, they occur outside the public health facilities. And majority of the child deaths occur without contact to the public health services. And 90% of deaths occur within 48 hours of onset. So it's an acute illness, we need to respond immediately. Self-medication are common and regulated informal private sector. Marketing artemisinin immunotherapy, despite all countries in our region adopted ACT, and the availability of fake and poor quality anti-malaria medicine. What we have done, I showed you the picture here from Afghanistan. This is a community-based health project, and the country developed a national strategy for scaling up the delivery through the community delivery mechanism in 2010, and it includes the deployment of the effective quality anti-malarial treatment medicine to the community people. what are the major strategic components and the market role here? To ensure availability of effective quality anti-malarial medicine in the community and its rational use, we need to provide the trained community health workers or the community sellers, medicines or drug retailers. With a recommended first line, high quality drug, should be pre-packed and should be provided with rapid diagnostic test. I have to highlight here the importance of diagnosis, and in all our initiatives in the region, we do not provide drug except coupled with a diagnosis because of the low malaria burden and the danger of giving the ACT to ill fever, which majority of them are in fact not malaria. And the drug has to be delivered through the whole drug supply management system in collaboration with the private sector, with the public sector, sorry. It's very important to provide the package with information and education to the community-based provider. We need to orient them how to recognize the illness and to take the appropriate action for mild illness, and to adherence is very important here, and how to assess severity, because within 40, if the child or the person is not responding, he has to be referred to the next level, which is the hospital for management of severe malaria. And here the picture from Sudan when we implemented the project, and it's provided to all community people here the information and the education package. Implementing this strategy is very important, yet we are facing many challenges, is how to set the community referral mechanism to manage the severe cases, and how to keep the record and the reporting tools, because to have the comprehensive picture about the cases in the country, we need to have the data from all the sectors, community, public, and private, and still the recording system in the community is not there. The quality assurance of ACT and RDT and the supervision and monitoring system. And the most important is how to keep motivation and the retention of the community-based provider if they are working on volunteer basis. I highlight here the achievement of Millennium Development Goals and the global target of 80% access within 24 hours of onset of symptoms should be through provision of quality, affordable anti-malarial medicine with diagnosis near to the home. Thank you so much.
Thank you so much, Hoda. And our final speaker on this panel will be Ramad Mabalasi, who actually will discuss the private sector approach focused on the drug seller through the accredited drug dispensing outlets. This will complement, of course, the community-based management approach that was more public sector oriented that Hoda was describing. Thanks, Ramad.
Thank you very much. The accredited drug dispensing outlet was an attempt of several questions that were raised before the intervention started. And you can see some of the studies that were done in Tanzania raise up a question which is very, very interesting, and I think I would like to work on this question for some time. You say drug shop regulations and malaria treatment in Tanzania. Why do shops break the rules, and does it matter? In fact, it does matter or doesn't matter. For the community, it doesn't matter as long as they have the medicines, because that's what actually they need. And for the drug seller, it matters. First, that he has to supply the medicines because they are not available in the area where they are, and people demand it. And secondly, it doesn't matter because he's also making business. But the question is, can they be regulated? Do they do that because of business? Or do they do that because they don't know what actually to do? And so the ADO intervention was very holistic in the sense that we tried to look into the cause. Why were they doing like that? Can they be regulated? And so the first thing was to build a private sector capacity. Can they really work? Can they really be told something to do? Can they follow it? And through this, you could see what was happening. This was a decrease in inappropriate recommendation of antibiotics for upper respiratory infection. You see before, during the assessment, before the intervention as a baseline, and the situation in the countries where, in the region where we had as a baseline control. You can see also in the presence of drug outlets dispensing malaria treatment according to the standard treatment guideline. before the intervention. They were doing that because they didn't know how to do it. And then after the intervention, but what is interesting is 10 years later, 6 years later, they were doing better than what we were doing before. We looked into also the quality of pharmaceutical products. You see a very high percentage of products which were not registered by TFDA. In the regulation whereby they are not allowed to get medicines from legitimate sources, they can get medicines from anywhere because the demand in their community is high, and therefore they wouldn't care about products which are registered or not registered. But if you teach them, if you train them, you can see what happens 6 years after the intervention. There is no product which is not registered by the authority, simply because now they are allowed to go into the official registered outlets and get their, what they need. Availability of anti-malaria, this is in Uganda, whereby the same program is actually an intervention is taking place in Uganda, and the results seem to be similar to what actually we experienced in Tanzania, where there was a high selling of chloroquine and SP. In the district of intervention, you can see a very high percentage of alu being sold in those shops. So there are some challenges. Of course, you can see some problems in the treatment of diarrhea. You can see that lack of minimal consumer education. In fact, the consumers are also a problem to the outlets because they don't know what they should expect from the outlets. So they demand everything. And with that, definitely fuels the behavior of the provider in providing products which are not really allowed to in these shops. Since we have only 5 minutes, I think I will have more time to explain to you when, during the discussion. Thank you very much.
Thanks so much, Romuald. Impressive findings, certainly the presence of registered products in local drug sellers and improved dispensing practices and for a number of conditions are clearly some of the early signs of promise for the ADOs. Now, we have actually, of course, laid out in the panel presentations and perspectives 3 different approaches. Clearly, a global drug facility green light committee sort of coalescing around DOTS and DOTS Plus for TB, a community-based public sector program for malaria, and the ADOs program, which actually focuses on the role of the drug seller. We'd like to put to all of our panelists some unifying questions that they might be able to discuss as a panel. And let me just perhaps start off and then also invite some of our plenary moderators if they also wish to add some additional questions as the discussion goes on. But given limited resources today, should greater investment be placed in scaling up private sector efforts or public sector efforts? How might we better integrate community-based and market-based approaches in scaling up access and rational use? Do you find that there are tensions between the 2 approaches, or are there areas for potential synergy among the approaches you're describing? Could we start maybe with any particular takers first? Hoda, you want to start?
Thank you, Antonio. I think there is a room for integration of the community-based, market-based, and public sector. As I mentioned, the delivery of the malaria treatment is a holistic. We start from home, the facility, and so we have to look at all care provider and to look at the health-seeking behavior of people. In some countries, the private sector played a major role. In some other countries, the public sector is a major role. We do not have a fixed formula for this. But we have first to assess and to make sure that since our goal is to provide universal coverage, then we have to make sure that we are covering all. I don't think there is a competition here. I think there is a partnership. It's an integration. I highlight the role of public sector. We cannot we cannot avail the drug in the public and give it to private. We have to avail it in the public because it is a public health disease. Malaria is a public health problem, and the public sector is taking care of treatment and prevention. So we have to make sure the drug is available there. Then we have to build the partnership with the private sector to provide the diagnosis and the treatment and monitoring, evaluation, and procurement. So to me, it's a holistic approach. It's an integration. There is a lot of complementary things, like the distribution channel can be, the cost of distribution to private can be reduced too much by integration with the public as well. Thank you.
Let me follow on just for a moment there, Hoda, and find out, since obviously in some countries which are now receiving AMFM monies, those monies could go to more community-based management or supporting interventions, or they could go more to co-payments to manufacturers to lower the price. Which do you see malaria as the major driver for actually change in your setting?
Okay, none of our region have AMFM. However, from my experience, AMFM is targeting the private provider, whether they are informal or formal. And the informal private provider is part of the community-based mechanism. So to me, it is also addressing the community, because the aim of AMFM to reach to the people, to reach to close, to deliver the malaria treatment close to the people where they are. So to improve access. My only concern is we are not taking care of the rational use here, because there is no element of diagnosis in AMFM. Thank you.
Maybe for TB, the story is totally different. You know, I fully agree with Dr. Hoda, because we, TB as well, you know, match the same scenario of malaria. It's a public health disease. However, the private sector here is very important. That's why a long time the initiative of BBM, public-private mix, you know, have been established actually to control, you know, the private sector in this concern. I mean, if the TB cases go to the private sector and asking for continuation of their treatment, you know, they have the private sector here have a big important actually rule, which is to refer the TB cases actually to the public sector. Recently, I understood that there is an agreement between the FIB organization and WHO in terms of the rule of the pharmacist, you know, in TB control. However, we should focus that the TB cases should be treated in the public sector. That's why long time WHO and is still continuing under the image of DOTS. As you are aware about DOTS initiative, which should be under supervision. The question here, do you think that the private sector, if we can provide them with the full resources of treatment, they can handle this story, I mean, DOTS initiative correctly? This is a big question. That's why the TB medicine should be under control. However, private sector rule here is very important to help the public sector for referring the TB cases to the public sector. In addition to, you know, there is a big initiative in the world right now who can actually control the TB medicine and everywhere, like GDF. Global Drug Facility, when they started, their image from the beginning to ensure sustainable supply of anti-TB medicine, not only just supplying, you know, but also to handle the service till medicine reach to the patient. I mean, control the drug management cycle all. So under such work, the work of private sector here is very limited to reach actually, you know, the global initiative like GDF in this concern. Usually GDF work with the public sector. Their image is to ensure cooperation between the private sector and a public sector for the sustainability of the work of GDF in terms of drug management. Thank you.
I'd just like to take the opportunity to ask a question on second-line drugs. That do you feel that the control mechanisms that was put in place to control access to second-line drugs through the GDF to the low-cost second-line drugs had any adverse effect on actually increasing access and the scaling up for MDR-TB. And when we have to make maybe this sort of decisions that what is more important, controlling the supply chain or getting a larger number of patients, what are the factors that you would need to consider than how you can make this trade-off between access and ensuring the quality and that these low-cost medicines are going into supply chains and programs where the rational use is ensured. Did we lose any pace of enrollment because of the controls but GLC imposed, or how this can be maybe in the future with the new framework probably speeded up a bit more?
I don't want actually to ignore the big rule of GLC and the wonderful work have been done by GLC in the past. GLC will continue with another scenario. I mean, everyone knows that right now the GLC initiative little bit stopped. However, the continuation will be decentralized. I mean, at the central level, at every regional office will continue work in GLC. But when it comes for the application, things that have been done in the past, this process completely stopped. However, an important issue we should focus on, that stopping of GLC or disappearing of the GLC initiative in terms of applications, monitoring the how many cases they showed, under the treatment, doesn't mean that we will stop work on TB medicine drug management issue. GDF is continuing work on this concern. Before GDF starting this work in second-line medicine, GLC was handling the procurement of anti-TB medicine, second-line medicine, was their procurement agent without control of the drug management issue. The issue was just dealing with the procuring of such medicine. By having the fact of GDF is continuing work in this area, we will ensure that sustainability of access of second-line medicine, pricing as well, high quality of TB medicine, because GDF, our concern is to work closely with a WHO pre-qualified supplier. So all what we aim for the other medicine, I mean first-line medicine, will continue working, for second-line medicine. So I would say that...
Thank you. Thank you.
Okay.
One question, is it we or the people who actually decide which one should exist in parallel? When I was a young inspector, I learned something. When I went to the rural communities, inspect how the small drug shops were doing, and collected all the medicines which were not allowed to be in these outlets and left, I later started feeling how the community was reacting to what I was doing. So by the time you reach the village and the community notes that you as inspectors have arrived, they will send a message to the drug outlet owners that the inspectors are around, and they will close all the shops. And when you come and ask the community, where is the owner of this shop? They will tell you, he has never been here for the last 2 weeks. It means the community has actually discovered that there is a gap that the public has not been able to fill. And therefore, the presence of these outlets is not a desire of the government as such. There is a force behind, because we cannot plug that gap. In that case, I think the best way for us to go is to help by improving the services that are being provided by these private outlets. We are actually trying to support the community that we are concerned. by closing the drug outlets, we are not actually going to improve quality of service. Because whatever the case, if there is a gap, drugs will be sold in one way or another. So for me, supporting both the private and the public is the only way forward. Because even when we have a gap, we know that they will be able to get medicines at of good quality and service as well. And therefore, I think it is important to work on both sides, support the private to strengthen the system, and support the public also to do whatever they can do. Thank you.
Thank you. Thank you very much. And if I can just, if I can ask now Anthony to draw this to a conclusion.
Thank you. Mine is just a comment. It doesn't have to be answered by anybody. But just drawing experience from Uganda, where we have the presentation about scaling up malaria in the community, at the home level and in the community. What that has done now, together with the rapid diagnostic tests rollout and scale up in the community as well, what it has done now is that the overdiagnosis of malaria that hitherto has been the case in Uganda has remarkably reduced. What we are seeing now is an increase in the diagnosis of pneumonia, which in the under fives were all together lumped as malaria, and the increased number of deaths in these children probably was ascribed to malaria when indeed could have been a pneumonia. The question I want to pose, but may not be answered here now, is both on the TB and malaria. The issue of market forces. For example, indeed what Jeffrey has said now is that in the private, drugs or medicines are diverted into the private because there is the demand side for it and they see the benefit. What I see is with the upcoming of the insurance schemes, if it is enforced, I think that will be one way that we can control the diversion of medicines from the public sector into the private, because then the difficulty of accessing claims or refunds for your medicine, for whatever medicines you have bought from the private sector would be rather difficult. But if it is accessed from the public sector, it might be a lot easier.
Thank you for those thoughts. And just on that, of course, on that striking note of unity among the panelists, of trying to bring together public and private, the range of perspectives on this panel have demonstrated the complex interplay of multiple stakeholders, of public and private sectors, of the different parts of the value chain with the need to ensure therapeutic and financial access to various both qualified ACTs as well as second-line TB therapy in scaling up access and rational drug use. Tying together this morning's plenary with some of those that have gone before and the one yet to come, there are no easy answers. The challenge is certainly worthy of the system's thinking complexity that Mariam Begdeli suggested yesterday that we embark on, and like the lack of infrastructure resources for rational use bemoaned the day earlier by Kathy Holloway, is not just a question of where to direct resources, but the need for more resources, which makes one wonder whether a great starting topic for Klaus Leisinger's proposed think tank might be to figure out how to realize perhaps savings from that 30 cents on the dollar of pharmaceutical company revenues dedicated to actually now marketing and administration, and improve corporate efficiency, and instead rededicate those monies and resources instead to the greater goal of rational use of these products. Would that really not take us some distance to actually a model of actually doing business differently? At least we've heard on the stage multiple times in the last few days, we need a new business model. Thanks so much. And thank you for all the panelists for their contributions.
May I now take the opportunity to invite Anita Wagner to present healthcare and medicine needs and access, their gender inequities.
Good morning. It is a great pleasure for me to share with you the work that my colleagues and I have been doing to try to answer the question, are there gender inequities in medicine's access and need? You see our working group here, Paula Shigby, Jao Karapina, Akanksha Pandey, Dennis Rostegnen, Peter Stevens Solbach, and Catherine V.I. Valentin. In 2007, Bill Gates was speaking to an audience, a segregated audience in Saudi Arabia. On one side of the audience were sitting men, and then there was a big panel division, and then on the other side was sitting what he described as a sea of black. And one of the people in the audience asked him, Mr. Gates, do you think that by 2010, Saudi Arabia can achieve its ambitious goal of being one of the world's leading economies? And this is what he said. So we are at a huge turning point in history where actually gender has made it on the global economic agenda. And it's about time that that happens, because we know very well about gender inequities in political empowerment, in economic empowerment, in education. And when it comes to health, gender inequities actually start before we are born, illustrated by this picture of the Indian girl with her 7 brothers testifying to selective abortion, which changes the sex ratio at birth from what it would naturally be 952 girls per 1,000 boys born, increasingly to much different ratios, in this case in Indian provinces, and that state of affairs is worsening in countries, certainly in Indian states and in other countries in the world. As women age, gender-based health inequities continue. One woman dies every 90 seconds for reasons related to pregnancy and childbirth. For each of those women, 30 others have suffer permanent disability that makes them oftentimes outcasts in their society. Physical security is not assured for women all over the world. In this slide, the darker green colors, which cover most of the world, indicate less than optimal physical security for women. So in light of all of those, the question arose as to whether what the relationships are between gender and medicine's access and need. This question has been brought to the attention in an article that Gitel Baghdadi wrote in 2005, where she looked at an international public health perspective and concluded that we actually need more data to fully understand the impact of gender on access and use of medicine, so that national essential medicines policies can actually be gender sensitive and introduce a gender perspective in their medicines policies. In 2010, Saul Walker from DFID called us up and said, I've been looking to find information on gender and medicines. I couldn't find anything. Do you know anything? And we said, oh, sure, there must be tons of it. And then we looked, and we also couldn't find anything. And then with the support of DFID, we embarked upon 4 studies to try to see what the relationships are between gender and medicines. And I'll share with you preliminary results of all 4 of them. We first looked at data from the 2002 World Health Survey. We picked 53 mostly low and middle-income countries where we look at household need for and access to chronic medicines for adults with chronic conditions and preventive care for children. In a project led by one of our fellows, Akanksha Pandey, she took data from 5 household surveys that WHO and the Medicines Transparency Alliance have developed to look at household access to acute and chronic medicines. Peter Stevens from IMS Health looked at data that are prescribing data. These are not the market share data, but the prescribing data for diabetes and depression and upper respiratory tract illnesses in 15 low and middle income countries. And João Carapinha and Paul Ajigbi have been doing a comprehensive literature review of the published and gray literature, looking at or trying to look at a comprehensive model, much similar to what we have seen in the frameworks depicted in the last couple of days, of care in a much broader health systems framework, to see what they can find with respect to gender and medicines access and use in the HIV, TB, and malaria literature. This slide depicts you results from the WHS analysis, the World Health Survey analysis. What you see is on the horizontal axis concepts that we studied in the surveys. What you see on the vertical axis is number of countries. You want to look at this in taking always 2 bars together. The bars indicate household respondent reporting of having been diagnosed with a chronic condition, arthritis, angina, asthma, and diabetes? And if they have been diagnosed, have they received treatment in the past 2 weeks? The red portions of the bar indicate the number of countries where more women than men report that they have either been diagnosed or treated. The gray bars indicate that the number of countries where equal proportions of men and women report having been diagnosed or treatment. And the blue proportions of the bars, the blue segments of the bar, are the number of countries where more men report having been treated or diagnosed or treated. And when you look at this, you see that for arthritis, for angina, for asthma, for diabetes, more women report that they have been diagnosed for these conditions. In 45 out of 53 countries, significantly more women have been diagnosed with arthritis. But once you look then at amongst those who have been diagnosed, what is the proportion of men and women being treated? And you see then that the gray segments really take up the picture. So in most of the countries, given a diagnosis, access to treatment seems to be similar for men and women. A similar slide, and what you take away from it, and this one looks at adult access to care and a child access to preventive care, vitamin A capsules, immunizations, and so forth. And what you see is, by and large, a gray bar, i.e. for most of the countries of those 53 that we looked at, the proportions of men and women, boys and girls, being reported to have access to these kinds of care are similar. When we looked at adjusted analysis, adjusted for factors that could explain these outcomes other than gender, we see that for the need-based measures, so having bad health, having a chronic condition, having arthritis, needing care, between 41 and 51%, women are between 41 and 51% more likely to report that they need care for these conditions. When we then look at access to care, we see that by and large, there's no difference in the likelihood of men and women receiving care, with the exception of, in this particular data set, women are more likely to report receiving arthritis treatment. Interestingly enough, women are more likely to report satisfaction with healthcare in their countries, and women and men don't seem to differ in the reporting of feeling discriminated against because of gender. Among children, there doesn't seem, in the adjusted analysis, we don't see differences in boys and girls having access to preventative treatment, having access to curative treatment, and it seems that boys are more frequently diagnosed with these kinds of symptoms or illnesses. However, when we look at access to, in this case, chronic treatment and preventive care for children, what we see across the countries, that access is actually equally poor for boys and girls and men and women. In that, in half of the countries, less than, say, 50% of both boys and girls have access to vitamin A or measles vaccines or DPT vaccines. So access is equally poor for both. Now shifting to the study that's based on a different data set, that one that is a particularly medicines-focused survey that WHO and Medicines Transparency Alliance have constructed, where ACA looked at different indicators of the care-seeking process and of receiving medicines and of adhering to medicines. And here are only a few of the indicators picked out. But again, what you see is that by and large, the reported symptom recognition, the reported care seeking outside of the home, medicines taken, the number of medicines purchased in private pharmacies, being able to adhere to medicines is similarly reported for for men and women, boys and girls. And the one difference that Akka found in these crude analyses was regarding the source of prescriptions. When she then did some more when they did some more analysis and adjusted for other factors that could explain this, she did not find any consistent differences in access to care, in the care-seeking pathway or adherence in cross-country analyses of these 5 countries. Shifting to the work that Peter Stevens has presented yesterday, where he looked at the number of consultations observed amongst practitioners in 15 countries compared to what the number of consultations that we would expect to happen based on the burden of illness reported in these countries from outside data sources. He finds that the directions of differences between what you would expect and what you see actually go both ways. And I've picked here only one slide of his work that encompassed depression, diabetes, and upper respiratory tract infection, in this case depression. So if the expected number of consultations among the practitioners equals the observed number of consultations, you would expect that in each country the dots for indicating the consultations amongst the middle-aged and the older population is sort of clustered around that blue line. But what you see is that the dots are sort of equally clustered around on both sides of the line. So we find that in some countries, women have more than the expected number of consultations, and in some countries, women have less than the expected number of consultations. But then, of course, there are country-specific differences, like here in Pakistan and here in Tunisia, where women are much less likely than would be expected based on the burden of illness, of a burden of depression in these countries amongst women in these age groups than what we would expect to see. João Carapinha and Paula Jigby really scanned the literature to see what has been published on gender and medicine in HIV, TB, and malaria. They found 105 studies of the effects of gender on outcomes, and their net of outcomes was cast really very widely. Most of them, as we would probably have expected, are in the HIV/AIDS treatment area, fewer in TB, fewer even in malaria. Although they looked very widely at a health system perspective of where gender and the system would interact, most of the studies that they found were focused on access to medicines and on adherence. And the picture again is such that there are studies where men have more access. There are studies that report more women having access than men, and then there are studies that report equal access for both genders. With respect to adherence, there is seemingly as a body of evidence that suggests that women are more adherent than men to HIV, to medicines in these 3 diseases. But then there's a large body that also says that the adherence is equal. So what do we make from these aggregate analyses at this point in this process of building a body of work? Well, we think that the data suggests that women more frequently report a need for chronic illness care. Amongst those who are diagnosed and who are known to have that need, there don't seem to be consistent gender inequities in access identified along the hypothesis with which we went into this body of work. However, concerningly, access is equally poor for both genders in many countries, and situations vary widely within countries, which those aggregate analyses, of course, don't get at. What we also have not looked at is quality of care. So when there is equal access, if there is equal access, is the quality of care provided to men and women equal? We don't know that from these data, and we need to actually look at quality of care measures, much like it is done in some work that is being presented here from Mexico. We also, of course, haven't looked into individual regional in individual countries, and so that is also needed to be done. Now, if this is true, what would explain what is certainly counter the expectations which have been phrased around access to medicines and use of medicines and gender? Well, could it be that there is a prevailing concept that men just aren't sick, or real men don't seek care? Could it be that women have more contact with the system because they are actually the caregivers in families? They take care of their children, they also take care of their husbands, and by virtue of their reproductive needs may have more frequent contact with the system, as the picture here suggests, where the women in the primary care, where the patients in the primary care setting largely are women. And then, of course, equal access may be good, but not so good if access is generally poor. So based on these preliminary results, what kind of recommendations can we make as we want to put a gender astute lens on policy and program decision making? One is that we have to keep equity in mind, and that is gender equity and socioeconomic equity, just looking at health and medicines and health systems policies as they are being made, and as we look at them through this kind of a frame. And we need to do that at all the levels of policy making in a comprehensive frame of health systems, as we have seen them depicted in different sessions throughout the last 3 days. We need to monitor the effects of programs and policies by gender and socioeconomic status and education and caste and indicators of potential different groups that could experience disparities. And we can actually do that because in the data that we usually collect in health facilities, on prescriptions, in household service, we actually have variables. We certainly usually have a gender variable, and hopefully increasing we have variables that could serve as proxies, if not as measurements, of socioeconomic status. And we can disaggregate the data and look specifically for how these results may vary by subgroups defined by these characteristics. And then, of course, we need sound comparative global and national research to specifically assess equity questions. And that requires multidisciplinary, multi-method approaches that also take care of the changing dynamics over time. After all, with more focus on these issues, things will hopefully be changing. So what are some of the questions that we can actually pose and may be able to answer in sort of the time coming after this conference? This is a framework of the pharmaceutical sector that Dennis has put together for the Medicines Transparency Alliance, and I find it very useful because it depicts the actors within different parts of the pharmaceutical system, organized according to the supply and the demand side. And within the supply and demand side, organized by the actors that play roles in the system, of course grossly simplified, looking at who brings medicines in the countries and who makes decision about the medicines in the country, looking at the large private sector where medicines usually are bought and who plays roles in there, and the public sector, and then very importantly looking at the demand side, at consumers, patients, community systems, at the increasingly important risk sharing, risk protection, universal health coverage insurance system. So what are some of the questions? Well, at the manufacturer or the supply side, are products that come into the country, that are licensed, are they the products that men, women, socioeconomically different groups need? Are they quality controlled? Are there budgets allocated for equally for meeting the needs, equally according to the need, meeting the needs of different population groups of men and women? And do the distribution channels actually bring the medicines to where men and women, boys and girls, the poor need them? In the provision of care, do women and men access the public and private sectors and the players within equally? And if not, what needs to happen at the different players so as to assure equitable treatment? Do standard treatment guidelines take gender differences into account? Does quality of care differ in the different sectors for women and men? Are trained health workers available that are culturally sensitive to the contexts for the culture of the country? And does everybody get treated respectfully? From the patient's perspective, does household decision-making and seeking of care and the consequences of negotiating for access to medicines differ by gender? And can men and women access and afford and adhere to medicines as they need them equitably? And importantly, in the increasingly prevalent and expanding risk protection schemes, where at the initial outset, insurance oftentimes happen for the employed, and the employed may be the men in the cultures initially, do risk protection schemes actually cover men and women equitably? And do they pay for gender-specific care and medicines equitably? So I leave you with this Chinese quote that says, "Women hold up half the sky, men supposedly the other half," and we want to go forward in the research and policy recommendations that we're making from our gathering here, to be sure that we pay attention to men and women and old and young and poor and near poor and less poor, so that people do have access to what they need with quality. And sustainably and scalably. Thank you very much.
Thank you, Anita. We have run short of time, ladies and gentlemen. I think Anita's presentation in the middle of it seemed to have busted the myth that there was a disparity between men and women in terms of seeking healthcare and getting healthcare. But of course, the questions she poses at the end are issues that we need to think about. The reality might be that actually on the ground there is that disparity, but we need to go out there and seek and provide concrete evidence to ensure that the acquisition and access to health and not only healthcare but medicines is equitable in the two genders. I will take the opportunity to thank the panelists here and the presenters and my co-moderator for a wonderful session and for your patience with us. We now move to the... Oh, there was some questions from... Is this from...
Yeah, we received some questions online. Maybe I'll just read them out quickly before we go. To what extent do you believe that support from these funds can be later sustained? I think this relates to the AMFM. How can the funds ensure the quality and rational use of drugs at country level? So these are questions, I think, for future discussions in maybe subsequent sessions.
That was from Egypt, I think. And I think we could now move to the next session. Thank you very much.